Hello, everyone. Thank you so much for joining today. We'll give a couple more minutes for some more people to join, and then we'll go ahead and get started. All right, so we will go ahead and begin. Good morning, good afternoon, or good evening to everyone, and welcome to today's webinar, which is hosted by Hepatitis Delta Connect. My name is Beatrice Sovich, and I'm a Public Health Program Manager at the Hepatitis B Foundation and the Manager of Hepatitis Delta Connect. Thank you all very much for tuning in today. So today's webinar will focus on the hepatitis delta virus, which continues to be largely neglected in many different parts of the world, and the particular barriers and challenges that it poses in terms of diagnosis, prevention, and linkage to care, as well as strategies for management, as effective treatments are not available or easily accessible in many regions at this time. We will be joined by experts from across the globe who will speak to their experiences with these challenges and who will discuss their particular work with the hepatitis delta virus. We hope that you find these presentations impactful and useful to your work, and that you come away with a better understanding of how best to screen for and manage HDV, all while more research continues to be done and a wider variety of treatments will slowly become more available. All right, so before we begin, I would just like to remind all participants that during today's webinar, all audience members are muted. We encourage you to use the chat feature to let us know who you are and where you are joining from. If you have any technical challenges, please indicate your issue using the chat box and we will address it as soon as possible. At any time during the presentation, you can enter questions into the Q&A box. Questions will be addressed by speakers at the conclusion of the presentations. This session is being recorded and slide presentations will also be shared. So just wanted to give a quick overview of the Hepatitis Delta Connect program. Hep Delta Connect is a dedicated program of the Hepatitis B Foundation, which was established in 2016 for the explicit purpose of raising awareness about hepatitis delta and promoting diagnosis, screening, research, and treatment, as well as support to those living with and affected by hepatitis delta through email and phone consults, social media, newsletters, our website, and webinars such as this one. We are hoping to continue to build and expand our programming throughout 2022, and we'll keep you posted about these developments and further opportunities to get involved. So today we are very excited to be joined and welcome a panel of 6 distinguished speakers from around the world. Each panelist will deliver a brief presentation followed by an opportunity for questions and answers. So today I'll introduce all the speakers at once and then everyone will present their presentation. So today we are joined by Dr. Marina Carmen Berenguer, who is a hepatologist and professor at the Universitat de Valencia in Spain. Dr. Zaigham Abbas, who is a professor and head of the Department of Gastroenterology at Dr. Ziauddin University Hospital in Karachi, Pakistan. Dr. Jose Debes, who is the Associate Professor of Medicine in the Division of Infectious Diseases and International Medicine at the University of Minnesota Medical School in the US, and is also the Director of the H2U Global Health and Health Equity Research Program. Dr. Richard Njouom, who is the head of the Virology Department at the Centre Pasteur of Cameroon. Dr. Domingo Balderramo, who is a provider of Gastroenterology and Digestive Endoscopy services at Private University Hospital in Cordoba, Argentina. And Dr. Raymundo Parana, who is a professor of medicine in Gastro-Hepatology Unit at the School of Medicine in Federal University of Bahia, Brazil. So without further ado, I will invite Dr. Berenguer to share her screen and get started. And a reminder to the audience to please put your questions into the Q&A box as they arise so that they don't get lost in the chat and so that panelists can address them at the end. Thank you so much.
Well, hello everybody. So I'm gonna share my slides. I think it's here. Can you see it?
Yes.
Okay. Okay. So I'm gonna talk But we did what we started 3-4 years ago, given that there were some new drugs in the pipeline for Delta, and we are a country with a history. It's in the Mediterranean basin, and we have a history of having quite a relatively high number, not high, but patients with Delta in the past, but it was kind of a forgotten virus. So we decided a few years back to start a first approach that I will show the results of that first approach, and then what we've been doing more recently. So the first approach we took was to try to do kind of a screening, trying to look in our database, our hospital database, try to look for the diagnosis of Delta hepatitis, infections with Delta virus, hepatitis B virus infection, and try to search how among all these HBV infected patients, how many had their anti-HBV V positive in serum. Then we collected variables related to demographics, epidemiology, particularly the country of origin, also about the clinical status, serological and virological data, and then we did an analysis of the data. So overall, we could find out with this very, I think, primitive search, which was kind of our first approach, about 600 HBV patients. And among these patients, we had 70 who had a Delta positive serological test, which is about 11% of our HBV population. The majority were male. The median age of this population was 52 years of age. The country of origin was 67% were from Spain, but we had about a quarter of our patients who were from Eastern Europe. And then in terms of transmission, pretty much half of them had not really an understanding of how they had been infected. And 20.7% had a background of potential nosocomial infection. And finally, 14% history of intravenous drug use. We found out that many had comorbidities, particularly 55% of our population were overweight or obese. A third of the population of Delta patients had alcohol, either past history of alcohol or present, and 10-11% were co-infected with their HCV or HIV. And it was interesting because these comorbidities were slightly different in men or women. So in terms of women, the transmission was mostly nosocomial, particularly in those coming from Eastern countries, whereas in men it was more an intravenous drug use way of transmission. Obesity was very common, but was more common among men. And alcohol was also a comorbidity which was more frequently found in men. And in terms of treatment, it was interesting that about a third of the patient had tried PEG interferon in the past, but there was no long-term responses for Delta. We saw that 77% of the patient had already progressed to cirrhosis, but it was interesting that this was significantly more commonly seen in those with the comorbidities that I just talked about, diabetes, particularly older age and lack of antiviral therapy. And in terms of progression to cancer, 17% of the cirrhotic patients developed cancer. And again, alcohol, a history of alcohol and older age was associated with the development of cancer. And then finally, I have to say that we are a reference center in our area for transplantation, and half of them had undergone transplantation. I think the most interesting part of this initial study that we did in our center was to look at the differences between before to the year 2000 and after the year 2000. So before the year 2000, the vast majority of our Delta population were of Spanish origin. The majority had been infected either unknown or through intravenous drug use, and 10-11% had a co-infection with HCV or HIV. And a few patients were HBe antigen positive at the time of diagnosis. Whereas more recently, only 33% of the patients diagnosed after the year 2000 were of Spanish origin. Many were from Eastern countries. the main way of transmission was nosocomial. There were no co-infected patients with HCV and HIV, and all were anti-HBE positive, and none was HBE antigen positive at the time that we saw these patients for the first time. And I think this kind of gave us, I mean, we are, as I mentioned, we decided that we needed to go and look for more patients, particularly in this population of migrants that are coming to our area. And secondly, we talked also with the microbiology unit to make sure that there was a reflex testing that could be underway in our microbiology. So since then, that was like 3-4 years ago, we now have the reflex testing, which is implemented in our microbiology unit. So every time there's a new diagnosis of HBV, there's automatically a serological test for Delta put into practice. And this was done because in our first kind of survey, we found that among the 600 and somehow HBV infected patients, there were 3 patients that had never been tested for Delta. So that we thought that we should put into place this reflex testing so that we would not miss these patients. And the second thing we are doing now is also going to the all these non-governmental organizations, trying to reach this migrant population to test all these people for Delta. And so far, we've just started this program 3-4 months ago, and we have already detected a couple of Delta positive patients among the migrant population, both of them from Eastern countries. We have a very a lot of migrants from Eastern countries, particularly in Castellón, which is a city which is 30 minutes away from Valencia. So this is kind of the idea that we are going to go on and progress for the next 2 years. We have this plan of going to the different centers in our area to implement the reflex testing and also try to make sure that we reach out to this migrant population. And I think this was pretty much what I wanted to comment today.
Wonderful. Thank you so much, Dr. Berenguer, for your great presentation and insights. It's especially great to hear about the reflex testing and the outreach that you're doing to migrant populations as well. So thank you very much. I encourage anyone to put questions in the Q&A box, but we will now keep moving forward and we will move to Dr. Abbas. To please begin your presentation. Thank you.
Can you hear me?
Yes. Perfect.
Okay. Thank you. So, as we know that hepatitis Delta is a real problem now, and the global prevalence of hepatitis D virus infection, according to a recent systematic review, was 4.5% among the hepatitis B surface antigen positive patients and 16.4% among those who are attending the hepatology clinics. Worldwide, about 0.16% of the population is Delta hepatitis antibody positive. This is about 12 million people who are anti-HDV positive. The prevalence is high in some of the countries like Mongolia, Pakistan, Moldova, and Western and Mid African countries. And it's higher in injecting drug users, hemodialysis recipients, the men who have sex with men, commercial sex workers, and hepatitis C and HIV infected individuals. But if we see the Amro region, in which Pakistan is also located, in Amro region, Eastern Mediterranean region, there are some countries that have a very high prevalence of Delta hepatitis. For example, in Pakistan, in the asymptomatic hepatitis B surface antigen positive patients, it is about 18.3%. Other countries that are having the high prevalence include Sudan, Somalia, Tunisia, Afghanistan. But if you see the countries, if you see the population who is having cirrhosis of liver, the prevalence goes very high in hepatitis B surface antigen positive patients, about 33, 34 to 40%. So in endemic areas, the risk factors may be different and the population suffering from delta hepatitis may be different. As in the previous presentation, it was mentioned that this is mainly the nosocomial infections, unsafe therapeutic injection and unsafe blood transfusion services, reuse of equipment without sterilization, and all these things lead to greater chances of having delta superinfection in patients who are already having surface antigen positive. But if you see and concentrate on this chart, you can see the erratic epidemiologic scenario in Asia. For example, in Pakistan, there is high prevalence of anti-HDV positive patients, but if you see the India, in the patients who are the surface antigen positive, their delta antibody prevalence is very low. The same is true for China and the neighboring country Mongolia, because in Mongolia there is high prevalence of delta hepatitis, but if you see the China, antibody against delta is much low, and this we can see also in some of the Oceania islands. So why there are discrepancies and confliction in the prevalence? It may be a failure to recognize the issue and perform the screening, lack of nationwide surveys, patchy information, because there is different denominators with we are targeting general population, low risk hepatitis B surface carriers, or high risk population. And prevalence may also differ if we are looking at the immigration population, like in the previous presentation, or whether we are looking at the vaccinated people, or what age group we are addressing. Most of the studies that have done have a small sample size. These are the studies that are coming from the high hepatitis B surface antigen prevalence areas. There may be difference in the mode of spread of infection, and performance of different anti-HDV assays may also vary. Most studies focus on HDV antibody, and there is limited data on HDV RNA. There is lack of funding and political will in the poor endemic areas, and this all leads to underestimation of the clinical impact of the delta hepatitis. The age of onset varies. Horizontal transmission we see more in our population in the endemic areas in sub-Saharan Africa and Pakistan, while in the Mediterranean region, many people present in their fourth decade. So we compared our children pediatric population who had the monoinfection of hepatitis B versus delta hepatitis. You can see the disease had already much advanced in the pediatric population who are suffering from delta hepatitis. Then we looked at the young adult population. If you can see in the young adult population, again, there was high prevalence of delta hepatitis, and hepatitis B E antigen reactivity decreased in these patients as compared to the pediatric population, and about 1/3 of the population had already developed cirrhosis. So in young adults, we are seeing many cases of cirrhosis, and this is one of our transplantation centers located in the endemic area of Pakistan. As you can see, delta hepatitis, the major indication for the liver transplantation, about 31% of the transplant delta being carried at this center of liver transplantation in Pakistan, they are the delta hepatitis young patients. So screening is important, and APASL and EASL both recommend that every patient who is surface antigen positive should be screened for anti-HDV, and if they are positive for anti-HDV, we should have the confirmatory test, which is the HDV RNA level. Regarding a little bit about the management, if the HDV RNA is detectable, ALT is elevated and moderate to severe necroinflammatory activity on biopsy or fibroscan showing the advanced fibrosis, these patients should be considered for interferon. We had standard interferon and pegylated interferon alone or in combination, and we did a Cochrane review. We showed that the standard interferon with 9 mega unit 3 times a week, the response was seen in 1/3 of the patients, This was end of treatment, but 6 months post-treatment, this decreased to 17%. But we were not able to see eradication of virus, but the overall survival until liver transplant or death improved much in the patients who are treated with standard interferon. So this is a long-term study which was published few years back. And these are some of the more recent studies with the pegylated interferon. In our patients, the response was 23%, 6 months post-treatment in these patients. And this is the sustained virological response in a recent systematic analysis, which was 29% 6 months post-treatment. What we found that if we have the negative HDV RNA during treatment at 24 weeks, these are the patients who are more likely to have more sustained response. And so if the surface antigen level also decline about 1 log at 24 weeks, then the chances of having response is better. And if there is a response, then these patients are going to have better survival and in the long-term follow-up as shown in the HEDED-1 study. Late relapses are not uncommon, so we should use the term sustained virological response with some caution. We did another study on lambda interferon, and we did not find any lambda 3 polymorphism, and we did not find any influence of IL-28B polymorphism on the response. He did 1 study versus he did 2 studies of a duration of 12 months versus 24 months. There was no difference in the response rate. And addition of the nucleoside analog, whether this is adifovir, tenofovir, or entecavir, does not increase the response to the pegylated interferon. But we still prescribe nucleoside analogs to our delta hepatitis patients if there is co-dominance of hepatitis B with HBV DNA level more than 2000 units, and we want to prevent any residual hepatitis B virus replication in patients with cirrhosis or advanced fibrosis. And when we are treating with pegylated interferon, we do give nucleoside analogs, because when we suppress the HDV level, HDV RNA level, there is a chance that hepatitis B virus flare may occur. So in conclusion, screening of hepatitis B virus is recommended in all the hepatitis B surface antigen positive patients. In endemic areas, children with hepatitis delta virus infection have the more aggressive disease than the hepatitis B virus monoinfection, irrespective of the hepatitis B e antigen status. Co-dominance of hepatitis B virus may lead to early decomposition in these patients. About 1/3 of the young adults in the endemic areas already develop cirrhosis, indicating the aggressive nature of the disease. Interferon is the only treatment in these endemic areas which is so far available, but it has got a limited efficacy, and it is contraindicated in decompensated cirrhosis. Addition of other nucleoside analogs does not improve the response rate. Minimum duration is 44 weeks, but prolonged therapy may be considered patients who are responding, but they are slowly responding. Ideal outcome is the loss of both HDV RNA level and loss of HDV RNA and surface antigen, which is difficult to achieve with the current treatment. As so long-term monitoring is needed in these patients even after treatment to detect late relapses. And these are the new treatments, ray of hope, alone or in combination with pegylated interferon. When we are talking about any hepatitis B control program, we should increase the public awareness, screen all the patients who are surface antigen positive, who are surface antigen negative. We should vaccinate. And these people, this is the only way to prevent delta hepatitis, and we have to address the risk factors to prevent the continued spread and treat and identify and treat the patients. Thank you very much.
Thank you so much, Dr. Abbas. We really appreciate the presentation and all of the highlighting the importance of screening recommendations and more surveillance and increased political will and funding, especially. So thank you again for your insights. And I will now pass it to Dr. Debes to begin your presentation.
You have to unmute.
Yeah, you're on mute, Dr.
Sorry about that. Can you see my slides right now?
Yes. All
Perfect, thank you. So I'll talk a little bit about hepatitis delta, just a brief intro in the epidemiology in the United States. First of all, thank you, Beatrice, and everybody also, the Hepatitis B Foundation and Delta Connect for this opportunity. And really in a few slides, what I want to tell you is a bit of what's going on with Hep Delta in our country here. If you look at the general epidemiology of hepatitis D in the US, it's about roughly between actually 4 and 7% of hepatitis B positive patients that are co-infected with hepatitis delta. I don't think this is too different than most of the world, although we're not a high endemicity area. Definitely our patients that are co-infected with hepatitis C or HIV have higher rates of hepatitis delta. And one important aspect that not we, but others have noticed here is that patients that use IV drugs also have higher rates of hepatitis delta when co-infected with hepatitis B. The most common genotype in the US by far is genotype 1, and it is actually, there's the second most common genotype is genotype 5. There is this concept that is not a concept, it's a reality that hepatitis B is starting to be more increasingly found among immigrant populations in the United States. So we're seeing more and more hepatitis B in our country, I think now, that are coming from immigrants that are not vaccinated. In this regard, I think it's impossible to talk about hepatitis delta without talking about hepatitis B. And this is something that we have aggressively focused, I think, with our refugee programs to test for hepatitis B and vaccinate those that are negative and don't have the vaccination. Now, although I'm talking about hepatitis B here, you would assume properly and correctly that the majority of hepatitis delta that we see in the US is actually related to immigrant populations. And although this is true, I think there are some points that are important to know. And I want to point out to this paper that came out in 2019 by the group of David Thomas and Chloe Thayer, John Hopkins, where they actually tested UN's enhanced hepatitis delta positivity antibody in patients with Hep B across the country. For those of you that are not familiar with ENHANCE, it's basically a data set that every 2 years tests random people around the country to try to get an idea of overall health parameters. This particular ENHANCE, I think, tested 21,000 people. And they found that the rates of Hep B were quite low, it's 0.36%, which is pretty accurate. But interestingly, they found that 42% of those hepatitis B positive patients had a delta positive antibody. So this is much, much higher than we have seen before. The interesting part of this study, in addition to the high positivity of antibodies, is that when they compared US-born versus foreign-born patients, there were quite striking differences. But if you look at US-born and foreign-born here, I'm highlighting in red in the hepatitis B positives, you can see there's a dramatic difference. So 1.3% of all those foreign-borns were positive for Hep B, with only 0.1% of those US-born. However, when you look at hepatitis delta among those that are positive for B, obviously the foreign-borns had more positive antibodies, but it wasn't that striking difference, which is leading us to think that there is a much higher rate of hepatitis delta among US-born populations than we think. And actually, this study and one other study, I look at hospitalizations for hepatitis delta in the country, show that it's a pretty high proportion of non-Hispanic whites that have hepatitis delta. This is likely, in my opinion at least, related to the opioid epidemic that we have. There's a lot of IV drug use in those populations, but it's a point that we need to be aware, at least in our country, as it's very easy to tend to ascribe hepatitis delta just in immigrant populations. Another paper that I wanted to bring up is a very recent paper from 2022 that looked at liver transplantation for hepatitis delta. And this group looked at the UNOS, the United Network Organ Sharing data over the last 20 years in the country. I'm sorry about the poor quality of the graphs here, but I wanted to focus on two things. This is the year 2014 to 2019, so the last 5 years. And look at this point here, which is, this is the number of patients with hepatitis B that were transplanted, that's 800. And this is the number of patients with hepatitis delta transplanted in that 5 period, which is about 22, if you look at this last part here. The reason I'm bringing this up is because if you look, generally speaking, at hepatitis delta with hepatitis B in the US or other places, it's about 5 to 8% of the population, 4 to 8% of the population that are co-infected, or more, according to a study I just showed you. But if you look at the proportion of patients transplanted for hepatitis delta, it's much lower. This is less than 2% of the hepatitis B patients, which tells you that we, A, are not doing a great job in reaching out to these patients, but more importantly, that these patients are probably not making it alive to the liver transplant, at least, which is quite a problem. I would say the good news, sort of, is that when this group compared the hepatitis delta with the hepatitis B survival after transplantation, they were actually quite similar, meaning that once you get to the transplant stage, your chances of surviving are quite the same as hepatitis B mono-infected patients. A couple of problems that I think that we have in general in the country that are beyond the treatment. One of them, there's a bit of lack of testing for hepatitis B. I think, generally speaking, providers don't do a great job here. We are trying to promote more testing, either not only in the general population, but also high-risk populations, like immigrants. I think there is a bit of lack of understanding between hepatitis D antibody and doing a PCR to look at RNA. I think we need to do both sequentially. I think both the speakers alluded to that before me. And this is something that is very important. That once you have this positive, you need to follow up with a PCR. And in my opinion, once you get one D antibody positive, you just follow with a PCR. You really don't have to retest this again. It is not easy, actually this is a mistake here, it is not easy to access for genotyping, at least for us in our country. I can tell you that every time I try to genotype for hepatitis delta, it is a bit of a problem for us. We do it, but it's quite a bit of work. In my opinion, this is important. There's a very clear difference between genotype 1 and 5 in terms of response to therapy, so I am a bit more biased to do genotyping to push therapy. And one important problem we have, I think, countrywide is a lack of intravenous drug use programs. A lot of countries, including Spain and Switzerland and the Netherlands in Europe, implemented IV drug use, lack of needle sharing for IV drug use. That had a very positive impact in decreasing hepatitis delta prevalence in there. We don't have this in the US, and I think that is a problem. Focusing a little bit in my own little niche here in Minnesota, where I'm in the US, in our institution, we have approximately 40 patients with hepatitis D that we follow. Very interesting, I think 6 of them are related, so there are 3 families. So we have literally 3 couples where husband and wife have actually hepatitis delta, both of them. The majority of our patients are from West and East Africa, mainly Liberia and Somalia. This is a bit in disconnection with the data I just showed you. And I can tell you the majority of our patients are from Liberia. And about 30% only have active hepatitis delta, which is a bit different than what you see if you look at most of the studies, which I would say about 60 to 70% have active hepatitis D. Some of the things that we try to do is here is to try to promote patient-provider rapport. The majority of these patients, as I'm showing, are from immigrant populations. Immigrant populations, depending on where they are coming from, they can be a little bit more hesitant toward trusting our medical care. So we try to create a really good rapport with those patients so they can trust us and we can do a good follow-up with them. I think this is very important. I do very close follow-up with these patients. So when they're hepatitis delta PCR positive, I look at their LFTs and their PCR a lot more closer than my mono-infected. And then we do try to enlist them early for liver transplantation. We don't have a lot of luck here. Overall speaking, immigrant populations, at least ours here, are a little bit hesitant when we talk about liver transplantation. So that has been a bit of a problem. And I do think, as other speakers mentioned, that trying to do more screening of hepatitis B and consequentially the hepatitis delta on those heavy positives is a critical step. Having said that, I'll stop and let the next speaker take the lead. Thank you.
Great, thank you so much, Dr. Debes. We really appreciate your insights, especially about highlighting the opioid crisis in the United States and how that is contributing to rises in hepatitis delta and the underdiagnosis. With that, I will pass it on to Dr. Njouom to begin your presentation. Thank you. We're able to see your slides, so you should be all set. And you are on mute, though. Dr. Njouom, you're on mute. If you're able to unmute yourself. There you go.
Is it okay now?
Yes, that's better. Thank you.
So thank you very much. Thanks for the invitation. I was asked to speak about epidemiology of HGV infection in Cameroon and the challenge of diagnostics. So as we know, viral hepatitis is a high and growing global problem. And the viruses that are concerned are hepatitis B, C, and G. And about 400,000 people are infected by hepatitis B and C in the world. And among the hepatitis B infected people, around 15 to 20 million are infected with FG. But the Asia and Africa continent are the most infected countries. Sorry, I don't know why it's not working. So in this meta-analysis that was conducted by a team in Africa, Sub-Saharan African have been divided in 3 different areas of endemicity of HIV. And we see that Central Africa are the most infected, with followed by West African and Eastern and Southern Africa. In 2011, there were a demographic health survey in Cameroon where around 15,000 people have been tested, aged from 15 to 59. And we test FG among those who were HBV infected. And as you see, we have around 1.5% people who are infected by HGV. And this prevalence was different according to different administrative areas. And we have the eastern and the southern region where around 50% people are infected. And I want to remind that these regions are located in the forests. And when we compare with the area in the world where we found the high prevalence of hepatitis D with Amazonian forest, it seems as there is a link between the plant viruses, the viroid, and the hepatitis D, because Central Africa are located in the forest, and there is an area where the high prevalence of FD have been found. And all these data have been generated through diagnostics, and diagnostics of HGV is essentially biological. And we are using in Africa, let's say, 2 categories of markers. There are antibody markers and direct markers. In the antibody markers, we have the IgG markers, which are the one that is widely used because available in the country. And we have the direct marker, which are antigen and RNA. And we have to show that the RNA detection are not conducted in Cameroon. We are doing about all the samples which coming from HBV positive are sent out of the country for testing. So the big challenge of the diagnosis in Africa, or in Cameroon particularly, is the lack of some of the tools to do the diagnostics and the cost also of these tools. For example, we have available in the country only the IgG antibody testing, and the cost is around $50 US, and it's not let's say, accessible for the people in the country. And regarding the HGV RNA testing, this is totally unavailable in the country. So we have to send samples out of the country. And when people have to pay it, it's around $200 US. And when we know that the HGV RNA is the most important marker that they use for the treatment, this means that the treatment is not also accessible for the people in Africa. I don't know why it's not working. So to conclude, I will say that in Africa, hepatitis D is a forgotten foe because we have most of the time dealing with malaria, HIV, and other viruses, other yellow fever. But hepatitis B is a forgotten foe in Africa. 50 years after its discovery, it remained a challenge for clinical research in Africa. The burden of this virus is probably underestimated in Africa. For example, we say that there is a considerable lack of epidemiological data from several countries, African, Cameroon included. There is a lack of awareness because people sometimes do not know why they have to do the testing of HGV. And as I told recently, the unavailability of appropriate diagnostic tool in the hospital. So HGV is not, for example, routinely tested in the clinical practice in many African countries. Thank you very much. That's what I want to share with you regarding Africa.
Wonderful. Thank you so much. Yeah, and I think that very much speaks to the challenge with tools and funding and priority, and how a lot of costs can be very prohibitive. So thank you so much for sharing those insights from Africa. And I will now pass it to Dr. Balderramo to share a little bit about hepatitis delta in Latin America. We can see your screen, so you're good.
Mute. Yes, my screen is okay.
Yes.
Sorry. Perfect. Yes. When I want to speak about hepatitis D virus in Argentina. I'm from Cordoba, from the Gastroenterology department of Hospital Privado, and I want to show some screening barriers around our country. First, Argentina is a country with very low prevalence of infection by hepatitis B. For example, near 0.20% of the donors in a 10 years period were positive for infection for hepatitis B, evaluated through HBS antigen. But in this 10 years period, more than 11,000 patients were positive for this antigen. Furthermore, a few cases are reported in Argentina. These are data from the National Direction of Epidemiology. And in 2020, for example, nearly 400 cases only were reported of hepatitis B, new cases. And in the same year, about 1,300 patients are receiving chronic treatment for hepatitis B. But what is very important, in a 10 years period between 2010 and 2022, no cases of hepatitis D was diagnosed in the current evaluation of patients with hepatitis B in our countries. 46 patients were tested for this virus and were all negatives. That's a very interesting finding according to the epidemiology of our country. Furthermore, the mortality related to hepatitis B is very infrequent in our country related to hepatitis D. Only in a 5 years period, 2 patients that were related to hepatitis D infection, what is very, very infrequently in our data. But what about the screening of hepatitis D in Argentina? Only 2 centers that are university and academic centers perform the evaluations through serology or PCR for hepatitis D. One center is located in Buenos Aires and the other in Cordoba, in the province of Cordoba. So no regular evaluation is performed in current care of the patients. These data are present for research evaluation in blood donors from Buenos Aires and Misiones. In a great proportion of population of donors from Buenos Aires, only one sample was positive in patients infected with hepatitis B, which brings a 2% of hepatitis delta in patients with hepatitis D. And no samples were positive in Misiones, another province of Argentina. But when Amerindians from Argentina were evaluated in the same province, there was an interesting finding. For example, 3 patients out of 46 samples with hepatitis B were positive, what brings a higher percentage of hepatitis delta in people infected with hepatitis B. Interestingly, all these patients were negative for HBs antigen and also were negative for serology for anti-hepatitis delta. Few data are from other parts of the country. Data from Cordoba that evaluates 77 samples with people infected with hepatitis B. In a 7-year period, found only 4 patients with anti-hepatitis D antibodies, what brings a percentage around 5%. Only 1 patient was positive in the PCR evaluation, and genotype was the only one evaluation performed. Interestingly, in the other patients that were evaluated in Amerindians from Misiones, also genotype 1 was the only genotype present. Finally, the recommendation for hepatitis D screening in our local society brings a specific situation. For example, a patient with infection of hepatitis B with severe inflammatory activity and low levels of DNA related to hepatitis B, patients with chronic infection of hepatitis B and rapid progressive of fibrosis, and patients with acute hepatitis B that present 2 peaks of increase of liver enzymes. That situation has the formal recommendation to HDV screening in our country. So, according to the barriers for screening hepatitis D in Argentina are possibly one of these. There is a possible underreporting hepatitis B cases in our country, and also only 2 centers perform serology and a PCR for hepatitis D, and these centers are universitary, are not regular care centers. Furthermore, the National Registry report from our country report very few cases and very few evaluation of hepatitis D in the last 10 years. So it's a very important point to evaluate in the future years. Science research evaluation found that 2 to 6% of patients with hepatitis B infection in our countries have evidence of hepatitis D infection, and genotype 1 was the more frequently. And finally, I think that another point to explain the barrier are the local screening recommendations that are restricted to very specific clinical situations and not for all people that are diagnosed with hepatitis B. Well, thank you for your attention, and I will respond to the question later.
Great. Thank you so much, Dr. Balderramo. It's very important, again, to highlight the importance of expanding recommendations and noting high prevalence underreporting of hepatitis B as well. So thank you so much, and we will now move forward to our last presentation, which will be Dr. Parana from Brazil. Dr. Parana, you're on mute. If you're able to unmute.
Okay, can you hear me now?
Yes, we can hear you.
Yeah, I'm having some trouble listening. I think the bad weather is causing some trouble in our Wi-Fi signal.
No problem. We can hear you and see your slides.
Okay. Okay. Let me see. So, thank you very much for the invitation. Good morning, good afternoon, everyone. In the next few minutes, I'm talking about Delta hepatitis in Brazil. And I'm quite sure that when I talk about Delta hepatitis in Brazil, Amazonia, I'm talking also the situation we see in other Amazonian countries, such as Bolivia, Peru, Ecuador, Venezuela, and Colombia. So Delta hepatitis was considered 30 years ago a vanishing disease, and now maybe it is a spreading disease with more than 30 million carriers close to HIV and even to HCV. But it is largely underdiagnosed, undertreated, underscreened, so very neglected disease. The case of Amazonia, including Brazil and other Amazonian countries, which is considered a highly endemic area, and hepatitis D is largely neglected. Talking about the screening in our country, screening for Delta hepatitis is limited to Amazonian inhabitants or people who lived or traveled to Amazonia. Only very atypical HBV case outside Amazonia is screened for Delta hepatitis. Maybe we have an enormous underdiagnosis of Delta hepatitis in our country, as well as in other countries, such as the United States. This is the scenario, epidemiological scenario of Delta hepatitis in Brazil, the most western country states, Acre, Amazonia, Rondônia, Mato Grosso, and Roraima, are the highly endemic areas. And you can see in the River Valley, intriguing epidemiological scenario. Neighboring communities have a very different, very disparity in terms of prevalence of Delta hepatitis. We do not have an explanation for this. In some areas, in some communities, 50% of prevalence among HBS, HG carriers, and in other, 0% of prevalence. It is also described in other highly endemic areas outside Amazonia. In Brazil, 3 genotypes are identified. Genotype 1 had been described in the last decade in bigger cities, maybe imported by Europe, but genotype 3 largely prevails in Amazonia. It's the main genotype in Amazonia, but now, more recently, genotype 8 were described in African descent communities in the northeast part of the country, in this area. ADV genotype 3 is the most divergent genotype among all ADV genotype, and maybe it is isolated in Amazonia for a long, long time. But we also have in this area the high prevalence of genotype HBV genotype F, which is also very divergent among all HBV genotypes. And we have a few data about HBV genotype F and the ADV genotype 3. ADV genotype F is close to the woolly monkey. It's a Epidena virus that was isolated from these monkeys in Amazonia. I think we have to look for an animal reservoir in this area, but it was never been investigated. Our group, in cooperation with the Lyon group, Christian Trepot group in Lyon, France, we described an interesting mutation among HBV Delta hepatitis genotype 3 patients, and this mutation was more frequently in non-F genotype. Maybe it is an adaptive mutation from genotype 3 to other HBV genotype, but we have no data about clinical consequence of these genotypes. This is an unusual case in Brazil. Young patients, many family members with HBV carriers, large splenomegaly. It's not compatible with the stage of liver disease. high globulin levels, high HBV DNA, and high HBV RNA. Most patients are younger, but during at the time of diagnosis, they have advanced liver disease. Almost 50% have advanced liver disease. How about diagnosis? It's a big problem in our country. We don't have easy access to virological tools, only in a few centers and few research centers. We have to work with histology and sometimes immunostaining for Delta in liver biopsy. It's really complicated. And we don't have access to ADV IgM. This is a big problem for us. So among all diagnostic tools, we have easier access to ADV IgG and restricted access to ADV RNA and immunostaining by liver biopsy. This is a peculiar case of fulminant hepatitis, become rare and rare in Brazil, but it is still described in northern Amazonian countries. As you can see, this is a fulminant delta hepatitis caused by ADV genotype 3 HBVF. You can see you don't see a large necrosis, a confluent necrosis, but these cells, called modular cells or spongocytes, with a central nucleus and the cytoplasm, the central nucleus surrounded by the fat drops. It seems to be a mitochondrial damage. Curiously, delta antigen is concentrated in these cells as well as the HBsAg. Both are concentrated in these cells. This peculiar type of delta hepatitis was also described in Africa too.
Dr. Parana?
How about, yeah?
I think your slides may not be fully advancing. Do you mind putting it in presenter mode? I'm sorry. And just, I think they're not completely advancing.
I cannot hear.
I'm sorry. I know, yeah, it's okay. I know there's internet issues, so it's okay, no problem.
Can I finish?
Yes, go ahead, no problem.
Okay, sorry.
That's okay.
It's difficult for, yeah. So in Brazil, we have a guideline for treating delta hepatitis since 2017. In this guideline, you use PEG interferon in monotherapy or PEG interferon plus NUCs, depending on the level of HBV DNA. If more than 2,000, use both combination. We have only this data here, 30 patients in a cohort study, most of them Amerindians. But it is intriguing because we had an interesting sustained virological response. Week 72, 72% were ADV RNA negative and 20% loss of HBsAg. You don't know if it is related to the peculiar genotype we had. So South America, we have a different disease from Europe and the US. Here, it's not restricted to group of risk. We have more autochthon case, younger patients, concentrated in Amazon, genotype 3 prevails with HBV-F genotype. We have problems, adaptive mutations. We have also peculiar fulminant hepatitis, aggressive chronic disease with large splenomegaly. Intrafamilial transmission is the main transmission route, but there are others we don't know. Thank you very much.
Wonderful, thank you so much. We really appreciate your insights and bringing your perspective from Latin America. So I know we are coming up on time. We do just have a couple of questions from the audience if folks can stay on for just a couple of minutes to address. So the first, I think these can be addressed to anyone, but the first is if there's any predictor of treatment response with pegylated interferon as in hepatitis C treatment past RVR or EVR. Does anyone have thoughts on that?
May I answer this?
Yeah.
Okay, in my presentation, I mentioned two predictors. One was if we do the HDV RNA level at 24 weeks of therapy, then we are able to predict. In our study, this was the negative RNA, but other studies have shown if there is more than 2 log reduction, then these patients are going to respond better. Another predictor is the surface antigen. If there is surface antigen decline of more than 1 log at 24 weeks of treatment, then these patients are going to respond better and more chances of having sustained virological response.
The one thing I would like to add, Dr. Abbas, that was great. There are some studies, some come from London and Erasmus in the Netherlands, that are showing that the genotype seems to matter also. Some studies showing that genotype 5 seems to have a better, actually much better response than genotype 1. So that's something at least some studies are showing as well.
Yes, because genotype 1 is more difficult to respond as compared to genotype. Even genotype 3 is very aggressive disease, but they respond very much better as compared to genotype 1. So yes, genotype 5, 6 and genotype 2 and 3, they respond better to the pegylated interferon therapy as compared to genotype 1. But unfortunately, in North America, in our country and in Mediterranean region, the genotype 1 is more prevalent.
Big problem, yeah.
Yeah.
Absolutely. Thank you so much. And then we'll just do one more question if we can. So this was about the differentiation between co and super infection and distinguishing that in terms of treatment. Do you have any thoughts on treating co-infection versus super infection and considering it mostly self-limiting, this asker writes?
So may I respond to it again?
Sure.
Oh, okay. Most of the time we are able to see patients with super infection. And the problem with super infection is that 80% of these patients go into chronicity and their disease becomes aggressive. But if you had a co-infection, and co-infection means if you are having simultaneous hepatitis B and hepatitis D infection, then chances of spontaneous clearance are very much high. And about only 5% of these patients go into chronicity. So these patients, but unfortunately, the anti-HDV antibody is not a sensitive test to pick up these co-infections, and the PCR is more pertinent in this situation. So co-infection and disease is very sort of severe sort of disease, but spontaneous recovery occurs in about 95% of the patients. In cases of super infection, about 80% of these patients go into chronicity and aggressive disease.
Okay, excellent. Yeah, that's important to note the difference for sure. And we'll just do one more question just so we have it in the recording. I think this is a good one. Does anyone have any insights on how best to encourage healthcare staff to test people who are living with hepatitis B for Delta virus? So I think just raising awareness and getting this into the consciousness of healthcare providers. There's any thoughts on that before we wrap up?
I think, Beatrice, it's just raising awareness. I think one point that we're trying to do is that there is this concept, at least in the US, that hepatitis is mainly West African immigrants. And for sure, West African immigrants have much higher rates, but some of the data I show you is that everybody with hepatitis B is at risk. So one thing we try to do is whenever we can, try to tell people that everyone with Hep B is at risk for Hep D. And so I think at the end of the day, it's just a matter of just awareness and just trying to push that in there.
Absolutely. Well, thank you so much for all of your presentations and your excellent insights and answers. I will just share the last slide that we have here. And just want to thank everyone so much for attending today. We really appreciate it, and we hope that you found the presentations to be informative and valuable to your work or your life, and that you can apply some of this information moving forward. We encourage you to complete the evaluation form when the webinar concludes, and a recording of this webinar and slide presentations will be emailed to all attendees. We also encourage you to sign up for our Hepatitis Delta newsletter for both providers and those who are living with hepatitis delta, to be added to our mailing list and receive regular updates about drug development, clinical trials, research, and news. And you can find these links in the chat, and they'll also be emailed out afterwards. So please feel free to reach out and get in touch with us using the contact information on the slide. If there's questions that were not answered, you can feel free to reach out to me via email, and I can try to connect you with speakers. And please visit our website for more information. Thank you so much again, and have a wonderful day. Thank you, everyone.
Thank you. Bye.
Okay, take care.
Thank you. Have a good day.
You too.
Thank you.